Thank you very much. Are there any burning questions before we break for lunch? Go ahead, please.
You mentioned the dilemma that many providers face in where to refer people when you get a positive pap smear. The AIDS Malignancy Consortium is doing a large study called ANCHOR to answer that question. 5,000 patients over 5 years at centers across the country. So that's a great place to refer people.
Well, actually, the person who was doing our endoscopies is participating in that study. So, I'm aware of that. Thank you. Yes, that is true.
And yeah, and just so people know, it's providers and patients alike are going to have to advocate that there be more people to do the endoscopies and follow-up treatment in their institutions. We're going to have to get together to demand that.
We'll take one more question just to try to keep on time for lunch. I'm sure the speakers will be more than happy to discuss. Go ahead, please.
Hi, thank you to all of the speakers. This is really fascinating. I would be curious to hear about best practices for HIV case managers who are having a caseload and serving clients who are getting older. So how can they take this the knowledge that they have in treating HIV-positive patients and serve that population well as they age?
Well, I mean, I think, I guess it depends on the care system in which you're working. I work in the VA, and so we have reasonably ready access to a number of supportive programs and supportive care. I mean, between physical therapy, although our geriatricians are not particularly integrated into the HIV care. But we have like psychologists and social workers. I think our social workers in the clinic are really vital to sort of the helping patients with the logistics of their care and sort of their lives in general. I think, the reimbursement for some medical care doesn't really provide reimbursement for some of the non-physician services. And I think to the extent that these services can be reimbursed, that many of the needs that our patients have who are aging really don't require the input of a physician at all, though I spend a lot of my time trying to facilitate a lot of these things. I think there could be, like more case managers and then more, I guess, in a more organized way, access to care. I had once suggested that maybe patients come in like for a Mayo Clinic physical, that wealthy Americans go to the Mayo Clinic and have this annual physical, that you could have a model where people would come in and sort of once a year get this total assessment of function, diet, psychosocial, depression, substance abuse, and then you could sort of then tailor their care for the rest of the year based on what you see their needs are from this sort of, half-day physical and assessment. And then other people said, well, they won't come and it's too cumbersome. But I do think that if you could implement something like that, you may be able to then tailor the care for an individual more to their needs.
So on that encompassing note on how to provide care, with a lot of questions and a lot of answers already, and a lot of models that we've heard today, a lot of the issues that have been brought up, I'd like to thank all of the panelists for their time, for their expertise, and for sharing with us issues and their thoughts that we will hopefully take home and continue to build on. Thank you very much.